Good morning. Welcome to Action Plan for Clinical Providers in Improving Hepatitis B Screening and Care Among African Immigrants. During the presentation, all participants will be in a listen-only mode. You may enter questions throughout the webinar by using the chat feature located in the lower left corner of your screen. Questions will be answered at the end of the presentations. Please make questions clear and concise. As a reminder, this webinar is being recorded. This webinar is sponsored by the Multicultural AIDS Coalition, the oldest minority AIDS service organization in New England, dedicated to mobilizing communities of color to end the HIV/AIDS epidemic. The Multicultural AIDS Coalition's Cultural Competency Series is supported by the New England AIDS Education and Training Center Minority AIDS Initiative through a grant from the Health Resources and Services Administration. The training objectives are provided. This webinar is designed to be interactive. Participants are encouraged to ask questions throughout the presentation via the chat box located in the lower left corner of your screen. Immediately at the end of the training, you will receive the evaluation. Keep your web browser window open, and in place of the webinar screen, a pop-up window will appear with questions. Please complete. The evaluation will provide vital information to help improve the webinar and also document who participated. Before we have our first presenter, we would like to get a sense of who is participating on the webinar. Please make a selection on the polling question on the screen. Okay, it looks like the majority of people here on the webinar provide services at other, with the second being at a clinical organization. On the next slide, you'll see, please select what your primary role is. Okay, it looks like the majority have a different job other than what we have listed here. Now I'd like to introduce our first presenter. Dr. Iyad Faisa is the Director of the Viral Hepatitis Program for Einstein Healthcare Network's Division of Hepatology, Center for Advanced Liver Disease and Transplantation in Philadelphia, Pennsylvania. He is board certified in internal medicine and completed his fellowship training in hepatology. He has been the principal investigator on a number of industry-sponsored clinical trials, as well as the co-investigator for many multi-center studies focusing on patients with chronic hepatitis and other complications of acute and chronic liver failure. Dr. Faisa joined Einstein Healthcare Network's Division of Hepatology in 2007 and moved to his current position in 2013. Dr. Faisa?
Thank you very much. Really, it's a pleasure to be here and talk to you about this important information. What I would like to do is basically give you about 5 important points at the end of my probably 25-30 minute presentation. Obviously, you have seen the objectives for this meeting, but my focus is going to be describing the epidemiology and risk factors for hepatitis B, specifically in African immigrants. I will also discuss about, what are the challenges that we face when we screen and dealing with as a clinician or as a provider addressing important issues in our immigrant community, especially in hepatitis B. I will touch base with you about the current protocol and guideline in regard to hepatitis B screening and treatment. Now, it would be appropriate to talk about the prevalence of and the burden of disease of hepatitis B infection here and worldwide. As you all know, that hepatitis B is actually the #1 hepatitis worldwide. In the current estimate, about 240 million people are affected with chronic hepatitis B. Now, when it comes to the U.S., over several efforts over the last several decades, managed to reduce the prevalence of hepatitis B, including through a universal vaccination and screening of pregnant women. But still, we estimate about 2.2 million Americans live with chronic hepatitis B. The majority, about up to 70% of these individuals, are actually migrated from what we call intermediate and high endemic area. My take in this map is those areas you see shaded in red are known to have a high prevalence of hepatitis B. This includes, as you can see, Eastern Europe, Asia, as well as Sub-Saharan Africa. And again, and people who are born and migrated to the U.S. will have a high risk of hepatitis B. Now, I have kind of a question about the true nature of these estimates. But as you can see, hepatitis B prevalence in each country in the continent of Africa can range from 2.5% and can go as high as 17.6%. Some average this estimate being 8.8% of Africans who currently live in African continent are affected with chronic hepatitis B. Why? It's also not only that the high prevalence, but we see that hepatitis B tend to be severe in nature when affecting in the sub-Saharan African population. Particularly, the rate of hepatocellular carcinoma and the severity of liver cancer is much severe or higher in individuals who were born in sub-Saharan countries. For example, as you can see, in patients, if they develop hepatitis B-related hepatocellular carcinoma, they tend to be younger. More men tend to be affected than women, but it also tends to result in higher mortality compared to that hepatitis B we see from different continents. There are several explanations were provided to explain why hepatitis B is severe in regard to hepatocellular carcinoma in Africans. One, we know that aflatoxins are carcinogenic, especially B1 aflatoxins from ground nuts, maize, and sorghum. Population chronically exposed to these aflatoxins in addition to hepatitis B have a high rate of hepatocellular carcinoma and a severe form of liver cancer. High iron exposures through iron cookware are also implicated as part of the explanation why 2/3 of individuals with hepatocellular carcinoma attributed to hepatitis B infection. The other important viral factor is the predominant hepatitis B genotype that we see in Africa is genotype A, which is also linked with liver cancer more than the other genotypes. We know that HIV co-infection with hepatitis B is much higher in sub-Saharan Africa, also contributing to the rapid progression of liver disease and development of liver cancer. So not only that in African immigrants are at risk of high prevalence or high rate of hepatitis B, but also if they have hepatitis B, they tend to be at risk of progression of liver disease quicker and also development of liver cancer. Now, when you come back to the U.S., several estimates, several reports indicate that the prevalence varied but tend to be high in African immigrants that range from 5.7% in some Kenyan community to as high as 16.5% in Liberian community. Again, these are estimates using surveys done in pockets of immigrant communities. But overall, as you can see, compared to the lower than 2% prevalence that we see in the general U.S. population, at 10.3% of hepatitis B is much higher, and it's a real problem. Now, the other sad part of hepatitis B in general is, we call it a silent killer because most people really are not aware of this infection. If you look at surveys done in the past, out of the 2.2 million people, maybe about 600,000 of these individuals with chronic hepatitis B are aware that they are infected. And sadly, only 50,000 of individuals currently receiving current treatment. Now, the risk factors for transmission of hepatitis B generally divided into, this is a blood-borne disease, generally divided into either horizontal transmission or vertical transmission. The point I would like to raise in regard to vertical transmission, a mother who is chronically infected with hepatitis B can pass the infection to her unborn child or a newborn during birthing process. In fact, an infant who is exposed to hepatitis B from mother with hepatitis B antigen positive chronic hepatitis B has a 90% chance of developing chronic hepatitis B. Now, bear in mind, if the newborn is appropriately vaccinated and received hepatitis B immunoglobulin within 12 hours of delivery, you can prevent hepatitis B in about 95% of cases. So this intervention is is effective if we know or if the mother is screened for hepatitis B. Now, the horizontal transmissions, again, high-risk behaviors include sexual contacts, injection drug use, exposure to blood or bodily fluids. Now, patients on regular hemodialysis need to be screened at least on a yearly basis. I think most important for me is those individuals or household contacts to an individual with chronic hepatitis B should be screened, as there is a risk of acquiring hepatitis B from their household contacts. Why? It's very important because then it's really focusing screening individuals with a high risk of acquiring hepatitis B in order to prevent household contacts and different, which I will discuss later on. Now, you probably have seen this. There are 4 phases of chronic hepatitis B infection. Some individuals are the 5th phase, which they call resolution. But the major 4 phases are the early one is immune tolerant phase, where once an individual is exposed to hepatitis B, there will be hepatitis B antigen positive state, where the individual will have high replicative phase, hepatitis B DNA will be high, and liver enzymes tend to be normal or low. These patients tend to have minimal liver disease, if at all. So usually treatment is not indicated in these individuals, and this can last from 1 to 4 decades. Immune clearance phase is heralded by the presence of fluctuating liver enzymes, which is a marker of active inflammation in the liver and active damage, and hence therapy is indicated in these individuals. Once an individual loses hepatitis B antigen and develop anti-hepatitis B, the low replicative phase, the old name of inactive carrier state, will develop. In this case, patients will have low viral load but a normal liver enzymes. If you actually investigate these patients, evaluate them for advanced liver disease, you probably see minimal change, if at all. These patients also doesn't require viral suppression therapy during this phase. The exception will be in patients who already have advanced liver disease or cirrhosis, which will require therapy despite the level of their hepatitis B viral load. Now, in some cases, after development of anti-hepatitis B antibody, patients might develop fluctuating viral load and hepatitis B DNA. This is a sign that they are in a phase of reactivation, and at risk of progression of liver disease and active inflammation. These are the group of patients, again, that which we believe require viral suppressive therapy. Very few patients, once they develop chronic hepatitis B, with or without therapy, can develop hepatitis B surface antigen loss. In fact, if a patient lose a surface antigen and develop antibody, we assume that the patient successfully clear the infection. I brought this slide because to show you the risk of advanced liver disease. Hepatitis B can cause death in patients either directly through liver failure or through development of liver cancer. The risk is real. Over a 5 years cumulative rate, we estimate a patient can develop, up to 38% of patients can develop cirrhosis. 1 every 4 patients can develop, on a yearly basis actually, can develop hepatocellular carcinoma. And it used to be a higher, a lot of people might require a liver transplantation, but the current state, with the advent of the introduction of effective antiviral therapies, we now see less and less patients requiring or liver transplantation. The third thing is, again, about 5,000 patients currently die of directly related to hepatitis B related issues in the United States, despite the availability of adequate therapies. Progression of liver disease is linked with chronic hepatitis B in the majority of cases. In fact, up to 40% of patients can develop chronic hepatitis B related cirrhosis, hepatic decompensation or hepatic failure, and liver cancer. As I mentioned, and again, the yearly risk of developing liver cancer, when a patient develops cirrhosis, can be as high as 4%. The risk factors for development of cirrhosis are listed, both environmental or host factors as well as viral or disease factors. I think from viral disease factors, the high viral or viral DNA, elevated liver enzymes indicating the progression of liver disease, the presence of prolonged presence of hepatitis B E antigen, which is a marker of high viral replication, are all markers that the patient is at risk of advanced liver disease. In fact, there is also evidence linking rapid progression of liver disease with hepatitis B, C, or D genotypes. The presence of basal core promoter mutation is also linked with progression of rapid progression of liver disease. I think some of the modifiable factors that we see is aflatoxin exposure, chronic smoking, ongoing alcohol consumption, co-infection with hepatitis C, hepatitis D, or HIV are also linked with rapid progression of liver disease. Older age, male gender, and Asian or African race is also associated with rapid progression of liver disease to cirrhosis. How do we manage these patients? Let me give you a summary. Now, one, we have to identify the individuals which are at risk, and we have to offer them a screening. If we find patients who are unprotected, they will require vaccination. And those patients who are diagnosed with chronic hepatitis B, they should be evaluated for therapy. Obviously, we have to counsel all patients in regard to their care, their ongoing care, and also care of their family and loved ones. If you have to treat, I will talk to you briefly about therapy, goals of therapy, but if we have therapy, then we have to get patients or link them to the appropriate provider and get them into treatment. Let's talk about screening. I brought this case, a Ghanaian guy, a 35-year-old male who came to this country about 15, 16 years ago with his parents. His name is Kofi. Now, he thinks that he received a vaccination for hepatitis B prior to coming to the U.S., but he doesn't know whether he was screened prior to that or not. Now, he heard about the community hepatitis B education and the screening, and he came with a question, really asking you whether he should be screened or not. He reported that he's consumed alcohol casually on weekends with his friends, but I think the question is now, does he need to be screened or not? And I would like to see what your response looks like, and I'll give you some evidence. So your choices are A, advise Kofi that he is immune since he received hepatitis B vaccination, or should we offer Kofi hepatitis B screening since he immigrated from hepatitis B endemic area, and we don't know whether he is previously exposed or not, or should we ask him to take a repeat hepatitis B vaccination? You can put your answer. I'm very pleased, and 86% of you think that we have to offer a screening. This is the reason, actually. This is one of the big problems that we see in immigrant community from any country with high endemic hepatitis B endemic rate. Because if an individual is previously exposed to hepatitis B, even if you try to immunize them, they probably will fail your immunization attempt. So it's very important to screen all individuals despite whether they received vaccination or not. Now, I take the different associations, including CDC, ASLD, and U.S. Preventive Service Task Force, to recommend that to screen any individual who were born and migrated to the U.S. From intermediate and high endemic hepatitis B countries. Therefore, we don't know whether Kofi was previously screened for hepatitis B. Therefore, it would be appropriate, despite his history of vaccination, to screen again. And the other most important thing which I would like to add is you also want to know if he is immune at this point or not. So screening will be appropriate. So what are the tests that we do? The other individuals that it's recommended to screen includes household and sexual contacts of individuals with chronic hepatitis B. All pregnant women in the U.S. currently will undergo screening. And also, based on high-risk behavior, you should screen men who have sex with men, injection drug users, individuals infected with HIV should have screening as well. In addition to that, anybody undergoing chemotherapy, for example, or disease-modifying agent therapy should be screened. Again, unique population include individuals undergoing regular hemodialysis should be screened at least on a yearly basis. So what are the the several markers that we use for screening? Hepatitis B surface antigen is the most important one. The presence of surface antigen indicates that an individual has an infection. If it is present for more than 6 months, by definition, this individual has chronic hepatitis B. If an individual has hepatitis B surface antibody, on the other hand, indicates that the person is likely is immune either through vaccination or previous exposure. To differentiate the two, the presence of anti-core antibody tells you whether the patient is previously exposed or not. Well, E antigen is actually, once a patient has surface antigen, you should check E antigen to define if there is a rapid virological replications or not. Hepatitis B viral load will be measured to define patients' the presence of high viral load or not in an attempt to define treatment. Once a patient is positive for hepatitis B surface antigen, check this patient will require appropriate evaluation for treatment and further evaluation for diagnosis. If a patient have surface, it turn out to be negative for hepatitis B surface antigen, check hepatitis B surface antibody. If that is negative, your individual will need vaccination. If a patient is positive, then they are immune to hepatitis B. Now, as you requested, as you advised him, Kofi underwent a screening test. His results shows that his hepatitis B surface antigen is positive. His hepatitis B core antibody is positive, but his hepatitis B surface antibody is negative. Now, the next question I have for you is, I'm sorry for the misspell of his name. Kofi is at risk for hepatitis B infection. You advise him to get vaccinated, or you think that he has immunity from vaccination and no further action is needed, or based on these variables that he has hepatitis B infection, and you send him for further evaluation and testing required. Now I'll take your answers. Very good. I agree with 67% of your response. Indeed, the presence of hepatitis B in coffee indicates, the surface antigen in coffee indicates that he has hepatitis B. In fact, if he has it for more than 6 months, which we believe, he has chronic hepatitis B. Very important things that you have to do is then make sure that he has appropriate vaccination for chronic hepatitis B management. Obviously, he will need to have virological data, E antigen, E antibody, hepatitis B DNA, viral load, liver enzymes, and so on, to assess his degree of liver disease and plan for appropriate therapy. Make sure that he has, you have to rule out other co-infection, including hepatitis D superinfection, hepatitis C co-infection, and of course, HIV co-infection. In addition to that, coffee cannot afford consuming alcohol, and you have to counsel him and educate him in regard to that. And again, it's very important, since he has chronic hepatitis B, then you have to advise him, counsel him to get to discuss and screen his household contacts and sexual contacts. And if they turn out to be negative for hepatitis B, they will require appropriate immunization or vaccination to prevent further exposure. Now, this is a simple way of interpreting the serological data. As our case, if there is a presence of hepatitis B surface antigen, your patients will require further evaluation. This indicates either acute or chronic infection. In the absence of surface antigen, you want to see if an individual has surface antibody or not. The presence of surface antibody indicates that a patient is immune, whether through vaccination, because hepatitis B core antibody is negative, or if it is positive, indicates that the patient was previously exposed and cleared the virus and now showing immunity, no further intervention required. Now, these are the people where you have to advise them that they don't have hepatitis B, but they are at risk. There is an effective vaccination they can benefit from. The typical vaccination course is 3 shots spaced out, first shot at the beginning, followed by a second shot within a month, and followed by a third injection at 3 months. Individuals need, in order to have effective protection, individuals need to complete all 3 shots. And there are commercially available vaccination now which compress this duration of vaccination into 4 months. We talked about recommended screening for hepatitis C, hepatitis D superinfection, HIV, and also if your individuals or your community or members, if they are not immune to hepatitis A, they should undergo vaccination and sometimes can be given with hepatitis B vaccination. How do we evaluate in coffee, because he now has chronic hepatitis B? This is where the confusion starts in regard to hepatitis B. There are different associations with their own guidelines, but the majority of them are based on the presence or absence of E antigen, the viral load level, high or low, or the presence or absence of abnormal liver enzymes at different levels, or in some cases presence of advanced fibrosis, either on biopsy or transient elastography. I prefer to discuss with you the US treatment algorithm, which was updated in 2015, which is a simple algorithm and practical, to be honest. What to recommend is, despite E antigen presence or absence, patients with hepatitis B DNA higher than or equal to 2,000 IU per ml in the presence of elevated liver enzymes, you have to offer these patients treatment. If liver enzyme is normal, then you can safely monitor this patient regularly. If the viral load is less than 2,000 IU per ml and normal liver enzymes, these patients should be monitored regularly. Now, bear in mind, the normal or abnormal cutoff for liver enzymes is quite different than what we get from different laboratory centers. For men, less than or equal to 30 units per liter is regarded as a normal cutoff point. For women, 19 units per liter is considered as a normal cutoff point. Now, how do we monitor these patients when they have normal liver enzymes or a different level of viral load? Well, what I do is I monitor these patients every 3 to 6 months with liver enzymes and viral load. And also, at some point, I will assess for liver biopsy and with liver biopsy or assess with elastography at some point, especially when they reach close to 4 years or so. Similarly, I'll check hepatitis B viral load on regular basis at least twice a year. Now, doing ultrasound with or without alpha-fetoprotein is very important twice a year. Hepatitis B-related hepatocellular carcinoma is a risk in these patients, in these individuals. So in anybody who has chronic hepatitis B, especially for African immigrants greater than 20 years, they should undergo hepatoma screening every 6 months with ultrasound and alpha-fetoprotein. And in fact, if there is a primary HCC or liver cancer in the family history, these individuals should be screened from the younger age. How do we treat? I'm sorry I didn't include the list of antiviral agents, but there are different options you can use at this point. Most of them are oral agents, can be taken once a day pills. But the goal of therapy is a durable suppression of hepatitis B DNA. And the challenge is, of course, the treatment, once you commit an individual for treatment, this should be taken for long term. Once viral suppression is achieved, you can achieve histologic improvement, ALT normalization. In some patients, very few cases actually can achieve hepatitis B E antigen seroconversion and loss of surface antigen in a minority of cases. These are the things that I monitor in patients, especially once I initiate therapy for the first 12 months. I'll check their liver enzymes and viral load every 3 months, and every 6 months thereafter, lifelong. Again, I will initiate hepatoma surveillance or liver cancer screening in all these patients. My principle is it's very unlikely to stop antiviral therapy in patients once they start therapy, particularly those patients who have advanced fibrosis, either F3 or F4. But the unique patients where they have F0 or F1, if they're able to seroconvert from hepatitis B E antigen to hepatitis B E antibody, you can consider stopping antiviral therapy and monitor them very closely. These, again, are the minority because the majority of patients will tend to have either detectable viral load or E antigen or the continuous presence of hepatitis B surface antigen. In conclusion, the few points I would like to make again. One, I hope with this discussion I brought to your attention, at least convince you that hepatitis B is, even if low prevalence in the U.S., the majority of individuals with hepatitis B are those who have migrated to this country. And patients born and migrated from sub-Saharan Africa or Africa have a high rate of risk of carcinoma related to hepatitis B infection. Unfortunately, majority of our community or immigrants doesn't know they have hepatitis B because they've never been screened. There is a lot of stigma associated with hepatitis B infection or in general liver disease. So we have our work cut out for us in regard to educating and helping individuals getting screened. In addition to individuals with migrate to the country, but patients, or a household and sexual contacts of individuals with chronic hepatitis B should be screened and vaccinated. And I talked to you or discussed with you about evaluation of chronic hepatitis B patients, counseling as well as treatment goals. I will stop here and I will give the podium to my other colleagues. Thank you.
Thank you, Dr. Faisa. Our next two presenters will specifically focus on tips for providers and partnering with African immigrant communities to implement activities for the National African Immigrant and Refugee HIV and Hepatitis Awareness Day that support earlier diagnosis and access to care for those at greatest risk. Sadie Slobodo is currently a program coordinator at the MAC's Africans for Improved Access program, where her work is dedicated to mobilizing African immigrant and refugee communities in Massachusetts to address increasing HIV/AIDS rates among this population. She also conducts research in this area. Ms. Slobodo holds a BA in International Development and Social Change from Clark University, Worcester, and is currently working on her MPH at University of Massachusetts, Lowell. As a community health advocate over the past 16 years, Chioma Anaji has focused on health equity, specifically geared towards mobilizing communities of color in Massachusetts to end the HIV/AIDS epidemic and broader conditions that fuel the epidemic. Currently, Ms. Anaji is the program director at MAC, where she developed and now directs the Africans for Improved Access program, an HIV prevention and screening program engaging African immigrants and refugees in Massachusetts, and directs MAC technical assistance and capacity building training. She holds a master's degree in public health with a concentration in international health from Boston University and master's degree in education from Boston College with a concentration in curriculum and instruction. She is working towards a PhD in global inclusion and social development at the University of Massachusetts, Boston. And here's Sadie.
Thank you, Rachel, for the introduction. So this part of the presentation will focus on National African Immigrant and Refugee HIV/AIDS and Hepatitis Awareness Day. We call it NAIRA Day for short. We will describe some effective strategies for providers in working with clients and communities to commemorate NAIRA Day. We will give you a brief overview and history of NAIRA Day. We will give you the importance of NAIRA Day, why we think NAIRA Day is important. And we will give you some tips and action plans that you could use, to move forward with NAIRA Day. And we will also give you some additional resources that, may be helpful in your choice of activity for NAIRA Day. We will start with a polling question. And the question is, how many years experience do you have working with African immigrants and refugees? Okay, so it looks like the majority of us have between 1 to 5 years working with African immigrants and refugees, 43%, followed by none. So about 21% of us have no experience working with African immigrants and refugees. The next polling question is, have you heard of the National African Immigrant and Refugee HIV and Hepatitis Awareness Day? Have you heard of NAIRA Day? Okay, so it looks like the majority of us have not heard of NAIRA Day. So about 65% of us have not heard of it, 35% of us have heard of NAIRA Day. So we're happy to have those of you who have not heard of NAIRA Day, and hopefully by the time you leave, by the end of this training, you would have heard of NAIRA Day and hopefully be ready to do something to commemorate NAIRA Day. So the National African The National African Immigrant and Refugee HIV and Hepatitis Awareness Day is September 9th. Every year, as you can see, that the logo to your left is our 2014 logo, and we changed that recently, about a week or two ago. So the one to your right is the current logo. We included the dates, September 9th, because we got a lot of questions around the date not being on the logo. And we also incorporated HIV and hepatitis in the logo. So that's our current NARA Day logo. So a brief history of NARA Day. NARA Day was birthed from a national effort that started in 2006, and a group of Africans and Friends of Africa gathered to examine, strategize, and collect information about African immigrants and HIV in response to the increasing cases of HIV among African immigrants living here in the U.S. A small group of individuals formed a national organization that was the African National HIV/AIDS Alliance, ANA, and then Office of HIV and AIDS funded a 2-day strategic planning session in 2012, and out of that, a priority was set to establish an awareness day. The awareness day was launched in 2014, and this is what is today the National African Immigrants HIV/AIDS and Hepatitis Awareness Day. So going forward, I will say NARA Day instead of saying the full name. So the purpose of NARA Day is to bring national and local attention to the HIV and viral hepatitis needs of African immigrants living here in the U.S. in a way that is culturally and linguistically appropriate. NARA Day hopes to get providers, organizations, communities, families to raise awareness, one, about HIV and viral hepatitis to eliminate stigma. NARA Day hopes to get individuals to learn about ways to protect against HIV, viral hepatitis, and other related diseases, to take control by encouraging screening and treatment, including viral hepatitis vaccination, and to get all of us involved by advocating for policies and practices that promote a healthy African immigrant community. So, there are currently about 11 federally recognized HIV Awareness Days that include the National Black HIV Awareness Day, the Caribbean HIV Awareness Day, and while these days are inclusive, they are not specific in addressing the determinants that fuel the epidemic in the African immigrant and refugee population here in the U.S. For example, our risk factors are different. The risk factors for African immigrants is different. Heterosexual sex is our main mode of transmission for HIV and for HIV/AIDS. We see a burden on women, which is different from the U.S. population, the general U.S. population. The burden of HIV is on women, African women living here in the U.S. There's not enough data that's specific to HIV/AIDS and hepatitis as it relates directly to African immigrants. We are usually put under foreign-born, or it's usually U.S.-born versus foreign-born. So we're either put under foreign-born or we're put under African Americans. And so there's not enough data that is specific to African immigrants. While even though we see that we have a disproportionate burden of the disease, we don't have numbers that are specific to our population. Also, there's this social and cultural diversity, and these awareness days are not culturally specific to address HIV in the African community. We're among hard-to-reach populations for many reasons, such as immigration, such as culture. A lot of different things prevent us from accessing health care here in the U.S. And so a lot of us, like you hear in the previous presentation, a lot of us here are not even aware of our HIV and hepatitis status because we're not using the healthcare system here. And then we're also a group that has increased stigma. While the stigma for HIV is, across the U.S. population, it's more for African immigrants and refugees for reasons that are also cultural and social. So to date, NARA Day, like I said, NARA Day was launched in 2014. There were inaugural citywide events across the country, in events at churches, events at African serving organizations. There were citywide proclamations. There was a national petition on change.org for the establishment of NARA Day. A proclamation was given by the city of Boston, Councilor Charles Yancey, at an event that was hosted by the Multicultural AIDS Coalition here in commemoration of NARA Day in 2014. So moving to 2015, last year, NARA Day launched a social media campaign on Thunderclap using Facebook, Twitter, all of social media, and we were able to have a reach of over 500,000 people and organizations. And through that social media campaign, we got a lot of HIV and hepatitis organizations that are global and national to, hear of NARA Day and support NARA Day. We also had a delegation on Capitol Hill in Washington, D.C. as part of Hepatitis on the Hill. We presented our case to our lawmakers in D.C. Last year, 2015. And we continued with the national petition on change.org. We continued with the national petition on change.org. The petition is still in effect, and so it's still open, and people can still go ahead and sign the petition. So I will turn it over to Chioma to give you some tips on that.
Thank you, Sadie. So Sadie gave a great overview of NARA Day, and I'm going to go through some tips that we've actually learned in implementing NARA Day activities here in Boston, but also in our work in providing technical assistance and capacity building to other organizations. So the first tip I would like to offer is that there are many options that can be done. I think often when we talk about HIV awareness days, not just NARA Day, but all, we only strictly think about events. But there are many options, and it really depends on who you are and the setting that you're working within, and it also depends on the resources that you have available, right? And so as a healthcare provider, you might only be able to maybe provide an announcement at a upcoming staff meeting about NARA Day is September 9th, because you know that your clinic provides services, has a significant number of African immigrant clients. Or maybe as a community-based organization as we are, we can actually do an event, and the event can range from having a community forum, doing a health fair, or even doing a press conference. Other things to think about are whether you're able to do it as an individual or organization. So some individual action steps that we support and that we think are just as important as doing organizational level or community level action steps is just posting on social media. Sadie talked about the Thunderclap initiative that we had last year, and individuals were able to sign up to say that we will have a NARA Day message posted on our Facebook page, our Twitter feed on September 9th. And that's just as powerful as doing a community event. Other things that we can think about as options, maybe as a political representative, actually hosting or doing interviews and info sessions with colleagues about NARA Day or the impact of HIV on hepatitis B. So the take-home message with this tip is really to think about and examine what are the options that you have based on your position in the organization or individual within the community, and based on the setting that you're working within, and based on the resources that you have available. So when we think about that, I just want to hear what folks would think about doing this year for NYRA Day. So would you be interested in doing an event? Would you be interested in holding some type of training within your organization or within the community, or individual action like social media, posting on social media, or doing something like an op-ed newsletter, or something that is more around advocacy where you're actually talking to your political representatives? So please select. Okay. So it looks like the majority of individuals would do individual actions that like posting on social media or even talking to your colleague about about NYRA Day. So the second tip is really to emphasize the need for partnerships. I think, you know, in general, we know the value of partnerships. And when we think about partnerships for NYRA Day, it could include clinical partners, clinical sites partnering with community organizations or community leaders who serve as cultural brokers and really understand how to take these messages to the community, can actually, you know, provide maybe an acceptable or appropriate venue for you. As community partners, there might be some community partners on the webinar today. So thinking about, as a community organization, reaching out to the community health center or the hospital to provide a presenter for maybe an event, or to provide screenings at an event. Our local and state health department and federal agencies are also great partners. We've done a lot of that here in Boston, where we work with our regional HHS Office of Minority Health, to actually support some of the events around NYRA Day. And our local and state political representatives, as Sadie said, we actually worked with a city councilor to have a proclamation made for NYRA Day. And then local businesses and community venues. We've done a lot of that work and working with local ethnic radio stations, African radio stations, restaurants to distribute materials. And so all of these organizations or sectors can be very meaningful partnerships for what you would want to do on September 9th for NYRA Day. Another tip is to plan, start early. I'm sure this might be a given for some of us on the webinar who do events on a regular basis or do mobilization activities, initiatives on a regular basis. And we actually start planning way in advance because of the diversity that's within the African community and the various ways in which we have to think about reaching out to our partners. And so we think about July as really the starting point, which is why we're actually doing this webinar now, to think about identifying partners and, again, looking at your options. What are you actually able to do effectively? And then August is where we think about maybe more partners once we have sort of the activity that we want to do. And, of course, focus on promoting within the community, promoting within our clinical sites. If we're a clinical provider, maybe doing some type of grand rounds around this topic, around African immigrants and HIV on September 9th. And then, of course, finalizing logistics. These are just sort of the bare bones of planning. And then September, of course, we implement the activity, and we encourage people to always do evaluations of your activity. When, last year for our social media campaign, we actually did a final report to look at, social media comes with a lot of sort of back-end data analysis that you're able to do to sort of look at who we were able to reach and who we were not, and sort of really think about what does that mean in terms of continuing our national initiative around NYRA Day. And then in October, we strongly believe that, September is not the beginning and it's definitely not the end. So in October, you want to tell people how successful your event or your activity was, and then look at ongoing strategies so that it's something that is talked about and done throughout the year, especially with African immigrant patients that might come into a clinical site. How can NIRA Day start promoting more of a narrative around increasing screening and supporting individuals and reducing stigma around these two diseases? And then, of course, it's always great to celebrate your successes. The fourth tip is to think about messaging. And with messaging, I think more about what is your target population, and based on your target population, what content do you want to put forth? And then also, what are the various mediums do you have at your disposal to actually provide that content to your target population? So maybe if you're working with African immigrants, you're talking about increasing knowledge, but also with providers, you could be talking about increasing knowledge. As we saw today, it was a majority of the individuals on the call didn't know about NIRA Day. So increasing knowledge about NIRA Day and the epidemic within the community is a great sort of goal if you're working within a clinical setting, and it's also a great goal if you're working with communities directly. With communities, of course, recruiting folks into screening. We always think about our mobilization efforts around building community action. So it's not just about that one day, but also engaging the community on how, as a collective or as individuals, they can take action. And that could be, of course, getting screening is the first step, but that could also be how can they establish a HIV ministry within their church, or how can they become a community health worker to actually be someone who promotes healthy decisions within the community. And last, a possible messaging is around increasing a response to the epidemic, and this might be geared more towards the local health department, the state, or federal agencies to really recognize that there's an epidemic within this community. And there are various mediums that we're all familiar with. Ones that we really focus on are more cultural in the ways in which Africans learn and teach. So we focus on using messaging that focuses on the we versus the I and the you. So it decreases the stigma on an individual level. And it also aligns with the African sort of traditional values around family and community first. And so thinking about how not addressing this epidemic is going to impact our families and our communities is a key messaging strategy for us. We also use a lot of African proverbs, which I'll show you on the next slide. And then we also use the arts, so thinking about how music, dance, and video, which is very much used on the continent, can help promote our messaging. So this is one example of a flyer that we use when we are at conferences or when we are talking to clinical providers around NIRA Day. That's one example. And these are examples of proverbs that we use when we're talking to communities. And this is not an either-or sort of messaging strategy, because we also use the fact sheet, but other ways in which we can communicate the importance of NIRA Day and the importance of screening for HIV and hepatitis. And these are actually examples that we used last year as part of our social media campaign. So the last two tips actually came from AIDS.gov, which is the internet portal for the federal domestic HIV and AIDS resources and information. And I felt that they were very much aligned with needing to talk about what are the resources available to actually support any initiatives that you may be thinking about for NIRA Day. So one, don't reinvent the wheel. Sadie mentioned that there are 11 other HIV awareness days. There's a lot of information out there around the possibilities for doing something on these awareness days. There's a lot of information about templates for press conferences, templates for doing editorials, templates for even flyers, templates for how do you invite community to the table. So there's no need to reinvent the wheel. which leads to tip 6, just research what's happening outside of your local area, and research in a way which you're learning more about the epidemic, but also learning about what are the other initiatives happening nationally or even regionally around this topic. So briefly, these are some resources available. We do have a NIRA Day toolkit, which was developed this year and last year because we updated it this year. Of course, the Multicultural AIDS Coalition is a resource, along with our partners, with our other leading partners, which is CHIPO and Hepatitis B. Of course, research-based articles, and there's another list of web-based resources that I've put up there that has great information around African immigrants and health issues, but also like Medline Plus and the Refugee Health Information Network. They actually have translation of health information in various African languages. Now, you're not going to find them all. There's like 2,000 African Nigerian dialects, so you're definitely not going to find all of the dialects or languages in Africa. But I think it's a very good resource if you're looking for translating some information. So here's our toolkit. It might be a little bit difficult to read, but it does have a lot of information. It gives you a very comprehensive background on the epidemic in terms of HIV and hepatitis B amongst African immigrants. And of course, we know that background is limited because, like Sadie said, there's a lack of research and information being distributed about the epidemic and the numbers. But we have all the articles possible to date. Also, comprehensive information about why it's important. That's a very, very important selling point that we found when talking to our local political reps and also talking to our local state health department. You'll have tools in there, so tools around the petition, the flyer, how do you write a letter of proclamation or engage your local political representatives in doing that. How do you do a media advisory? How do you do a calendar alert? Because there are a lot of community calendars that you can usually post information for free. And so it also has an extensive list of resources that are available to help make sure that you have the correct data in place and that you are able to also talk about, if you don't do HIV/AIDS and hepatitis work on a regular basis, actually be able to incorporate that in some of your messaging. Here are some of the articles that are available around this topic that I found as being some of the key articles around this topic that I use in all my proposals and conversations with folks who are not familiar with the epidemic. And so these are also listed in our tool site, but our toolkit, but you'll also get these slides afterwards so that you can have this list. Lastly, I do want to emphasize that there's other research, and I put it in quotes, happening. There are local grassroots organizations that are doing this work every day that have valuable information around this topic. And it might not be in the sort of standard research-based format, but it is based on lived experiences. It's based on program development and program assessment work, and it's based on working with communities on a day-to-day basis to address these issues. So these are the three that I've worked with in the past. There is one actually in Seattle that I wanted to mention, the Somali Health Association out there. But there are, I'm sure I can guarantee you that there are these type of organizations in at least one in every metropolitan city that have high numbers of African immigrants being resettled or migrating. So please use them as a resource also. So lastly, I want to encourage you, the majority of people said that they are interested in doing an individual action step. so I wanted to provide that as a opportunity where you can link to our Facebook page and you can link to our Twitter page. So please take a few seconds to do that after this webinar. Lastly, just to remind you on the NIRA Day is September 9th, and we know that events can happen throughout the week. Last year we actually even did an event at the end of the month on the Hill in Washington, D.C. So there's flexibility there too. And I wanted to also acknowledge the lead organizations that are responsible for mobilizing nationally around NIRA Day. So thank you from me, myself and Sadie. And I'm going to turn it over to our moderator.
Thank you to all the presenters. Now we will answer the question that was posed during the webinar through the chat feature. So, Dr. Fesa?
Yes.
The question is, what if African immigrants don't see themselves at risk? How do you offer screening?
This is actually a very good and practical question that at least I encountered in different community education and screening programs in the past. Indeed, most of individuals don't see that they have the risk. And as I mentioned earlier, actually hepatitis B is called the silent killer because most people don't have symptoms. Hence, if they don't have symptoms, they don't see that they're at risk. I think what we do is, we have to educate, give them the data, why, I'm born and raised in Ethiopia before coming to this country. Indeed, I have to undergo screening, knowing that, I don't know what kind of the risk I have during my life and back home. The vertical transmission is a major risk still. And this is the same for the majority of people coming to this country. So I think what we can do is just educate individuals that they are at risk. I'm sorry to say there will be few individuals which still they don't get convinced, but at least you can start the discussion and encourage them to consider screening at some point.
Thank you, Dr. Fesa. If you have additional questions, please post them in the chat box. Thank you to the presenters and participants. Thank you for participating in this webinar on Action Plan for Clinical Providers in Improving Hepatitis B Screening and Care Among African Immigrants. If you have any questions, please contact Chioma Naji. Contact information is provided. Immediately after we close the webinar, you will receive the evaluation. Please keep your web browser open and the evaluation will appear immediately. Please complete. The evaluation will provide vital information to help improve the webinar and also document who participated. Thank you again.
Thank you.